Good evening or good afternoon. Thank you all for having the patience to stay with us till this point in time in the program. A few quick housekeeping issues. My name is Dr. Ayodeji Adegunsoye, so I have the unique privilege of chairing this session. So a few housekeeping notes. If you're a respiratory therapist, please be sure you've signed in for the conference in order to attain your CE credits through the AARC. I'm made to understand that the sign-in sheets are located at the PFF registration desk at the bottom of the escalator, so they'll be waiting for you right there. I'll be introducing our first speaker, Dr. Tim Whelan. So Dr. Tim Whelan is a professor of medicine and medical director of the lung transplant program at the University of South Carolina, the Medical University of South Carolina. He specializes in the care and management of patients with severely advanced lung disease and lung transplant. In addition, he's an educator and an established clinical trial researcher with over 15 years of evaluating the safety and efficacy of new therapies for those affected by pulmonary fibrosis. He's also the director of the PFF Care Center at MUSC, where he and his colleagues strive to educate pulmonary fibrosis patients about their disease, as well as offer every single patient an opportunity to participate in clinical research. Please join me in welcoming Dr. Tim Whelan for his talk. Thank you.
Hello, everyone. So I was tasked with talking about the lung transplant evaluation and the transplant itself, and I have 40 minutes to do it. So I'm not likely going to cover everything in depth, but I thought what I would do is I would talk a little bit about what I think most of you are interested in, which is really the process of how you get to transplant. And then I will talk a little bit about the after transplant, but really my focus was to try to help folks kind of navigate that journey to transplant. So to help me do that, I'll tell you a little bit about me. So you all heard I do a lot of research, so there's a lot of drug company names on there. I've been heavily involved in lung transplant since the start of my training, so I've been doing that for about 20 years now. And I'm also very heavily involved in the organ procurement organization, We Are Sharing Hope in South Carolina. So that's how I spend my day working, and when I'm relaxing, I'm trying to catch fish is usually my latest hobby. So now you know a little bit about me, so now I want to try to know a little bit about you all. So how many folks in the room have been diagnosed with pulmonary fibrosis? Okay, excellent. All right, so we got a nice big cohort, and you guys are going to help educate me as much, I think, during this session as I'm going to hopefully help you. So I'm curious, how many of you are actually cared for by one of the PFF Care Center networks? So it's like maybe about half of the group, maybe a little bit more than half of the group that raised their hands. And then how many of you receive your care where there's also a lung transplant program? So actually maybe a little bit more of the group, so that's good, all right. And then is anyone right now undergoing an evaluation for transplant or started that conversation with the transplant team? All right, awesome. Okay, good. You guys are going to really be able to help out the folks that are maybe thinking about doing it, so that's good. And then I'm curious, of all the folks that are in the room here, how many have actually had a discussion about transplant with their providers that lasted more than 7 minutes in time? So we shrunk down a lot. Okay, all right. So it's an interesting thing. So I'm going to talk a little bit about that, and I think it's one of the biggest challenges that we have as a community. My personal belief system is we need to make sure people know about lung transplant. So I have several take-home points here. Referral. Timing, earlier is better. So the individual course of disease is really tough to predict. The full evaluation takes time. And so to help us out and to help you out for this opportunity, I came up with 4 R's. Now, the third R, I got to tell you, I was stretching. So if somebody has, is good at this and can come up with a third R that's better, you can definitely come up to me afterwards. So records, rehab, recent primary care, and resources. These are the 4 R's that if you're thinking about transplant, I think that these are really good to be thinking about right from the get-go, right from the start. And then listing for transplant, it really does depend on where you're located and what transplant center you're at, how they think about that. Each of us does that a little bit differently, and so I'll bring that up too. And then the last thing is transplant, it's pretty cool. So, all right, so who should be referred for pulmonary fibrosis? So this is right out of our International Society guidelines of who should get referred for transplant. So this is the International Society of Heart and Lung Transplant. And it basically says anybody who has a histopathologic, so a biopsy, or a CT scan that looks like UIP or fibrotic NSIP, regardless of their lung function. So what that means is if you have a diagnosis of IPF, you're supposed to have been referred to a transplant program already, the moment you got the diagnosis. That's actually the consensus guideline recommendation. So abnormal lung function is also something that should get you referred if you have PF, so pulmonary fibrosis of maybe a different etiology. If you got lung function that shows your forced vital capacity is less than 80% of predicted, which is pretty early, or if your diffusing capacity is less than 40%, which is, that's a measure of how well does oxygen get into your bloodstream, that's pretty severely affected. And then anybody who has any kind of functional limitation or a shorter breath. So you'll see that the guideline for the ISHLT really basically is saying anybody with a diagnosis of pulmonary fibrosis should be referred, particularly the group of patients that are idiopathic pulmonary fibrosis, because we know that the likelihood of progression is significant. So just here in the room, I started with who's got a diagnosis of pulmonary fibrosis and how many people have had a conversation for more than 7 minutes or so. It really is a fraction. So we're not really following the lung transplant guidelines, and I think that there's reasons for that, and maybe some good reasons, but that's at least not what the recommendation are to docs. So we can really help out our docs by saying, hey, so tell me about lung transplant. So we tried to look at this. I'm part of the IPF Pro registry. The IPF PRO registry is a registry that's co-funded by Boehringer Ingelheim and the Duke Clinical Research Institute and many centers, and there's overlap with the PFF. It's very similar to the PFF registry. We have now over 1,000 patients with a definite diagnosis of idiopathic pulmonary fibrosis in that registry. And at the time that I looked at this data, it was much earlier. The first patient was enrolled in June of 2014, and we looked at this data in May of 2016. And what I was particularly interested in is this question of, like, if we're supposed to be referring everybody, how many are we actually referring? And we asked patients in that registry, have you been referred for transplant? And so what we showed was that of about 330 patients at the time that that we took this slice of data, we removed folks who were over the age of 75, and there's some debate about that, but we said we'll just try to really capture as many quote unquote reasonable referrals as we can. So if you're over the age of 75, we excluded you. If you were overweight with a body mass index greater than 35, many transplant centers have pretty significant weight criteria for folks that they want people to get to, and so that's a pretty high limit for that. And then if you're actively smoking, we're probably not going to consider you for transplant, so we excluded those groups. We got down to what we thought was about 176 folks who were eligible for transplant and looked like they met those criteria that I just showed you. And of those, 41 looked like they were referred for transplant and 135 were not. So I can tell you that we tried hard to get this thing published, and despite trying multiple times, multiple different ways, folks didn't want to publish this data. And honestly, the reviewers, they were disbelieving of the data. They're like, that's not quite right. those 135, they're not referred because you guys are just not capturing how sick they are, that they have other contraindications to transplant. And I think that there's some truth in that. I think that this is, of those 135, I don't know that 135 are really good candidates for transplant. But I do think that this does demonstrate the problem that I just showed in the room. We're not talking about a potential therapeutic option for folks with IPF. So where is that disconnect? And I think it comes from the doctors that are really smart and taking care of our patients in the interstitial lung disease clinic, but maybe are not transplant physicians or don't have a lot of exposure to transplant. So we have a list of absolute contraindications for transplant that the society put out. And I kind of highlight a couple things because the absolutes are maybe not so absolute anymore. So in particular, uncorrected coronary artery disease. That's a tough one because it really depends on what one's definition of uncorrected is. There are some centers that will do bypass at the time of lung transplant. It's high risk. It's a high-risk thing to do, but there are some centers that'll do that. There are many centers that will do all sorts of coronary interventions on folks and then deem them okay to get a transplant. So that's a real gray area. That's very hard to figure out if you're not the actual transplant center. And then malignancy is another one that can be a challenge. So folks that have malignancies, for this guideline, 5-year disease-free is prudent. I think everybody will agree on that if you have 5 years of being cancer-free, that's much better than not having that. At the same time, so what about 4.5 years? Is 4.5 years okay? Well, so you really got to talk to the transplant center. But if folks have these guidelines in their head and they're making selections before you ever get to the transplant center, I would argue that's maybe not the best strategy. Maybe we would need to be a lot more inclusive. And the other thing is that transplant centers also will send things back to folks that say, yeah, what are you doing sending that patient to me? They have a diagnosis of cancer, within 2 years. And so there's all this feedback that goes back and forth that makes it hard on the referring docs. My bias is that we should just welcome all those referrals. We look through everything, and then we say, this one's not good because of this, but please do keep just sending them to me. Don't really think. Just keep sending me. It's okay. I'll sift through everything. So the relative contraindication is another thing that's really difficult. So age greater than 65 years associated with a low physiologic reserve and other relative contraindications. It's totally and completely vague on purpose. Right now, about 1/3 of the list wait list in the United States is over the age of 65. It's actually almost 40% of the list is over the age of 65. So this guideline, it was published in 2015. It's actually from meetings that happened in 2014. So things have changed a little bit. No clear upper age limit, but folks over the age of 75 are unlikely to be a candidate. And I think that that's still true. That's a very small fraction of the transplants that we do. But again, the folks that are going to be the ones to decide that are likely the transplant center, not the referring doc. And then non-curable chronic extrapulmonary infections. HIV, one of my colleagues who I was having dinner with, he told me they just transplanted someone with HIV this week. So there are centers that will absolutely do transplants on HIV-positive folks. So there is a lot of leeway in all of this, and I think that leads to confusion on the referring doc side and makes it really, really, really difficult to sort through that. So who's the best person to make sure you get that referral? Honestly and truly, it is all of you. You may not be a candidate, but you have to be an advocate for yourself. I think if there's one thing you carry away, be an advocate for yourself. So transplant centers, also this feedback loop that we give is that we are often really thinking about who we want to get listed. And so when we have conversations with referring docs about what's a good candidate for transplant, if we're not careful, we'll be talking about who we want to actually list for transplant, not who do we want to meet and talk to about transplant. So the ideal person to really list for transplant is someone who has a high risk of death over the next 2 years, has limitations, significant limitations, and oftentimes for pulmonary fibrosis, oxygen is a good marker for that, particularly oxygen at rest. And then someone who really and truly They've got the wherewithal to get through all the things that I want them to do, and they've really got good support. And so I'm going to talk a little bit about that. That's kind of the resources aspect of the 4 R's. So I often get asked, well, listen, you really don't want to see everybody. We don't want to overrun your clinic. Why don't I just refer them when I think that they should be listed for transplant? Well, the biggest problem with that is that IPF in particular and PF globally is a real heterogeneous disease. So there are definitely folks who can kind of cruise along over time, and they have a slow decline, and they just steadily go and go and go, and we might be following them for forever. Unfortunately, we also have folks who they present to us, and they're not around within 6 months. And then we have a group of people that look like that they're fine, and then they look very similar to the folks that are not around in 6 months. And unfortunately, one of the frustrating things for me as a transplant doc and a pulmonary fibrosis doc is that I know that that is your most important question. You want to know which one of these you're going to be, and I can't tell you. The only way I can tell you how you're going to do is by following you over time. Okay, so now you've been an advocate for yourself. You said you made them sit there and talk to you for 8 minutes about transplant, and they said, fine, I'll send you. So now what should you do? All right, so it's a really, really good idea to be prepared. So records, the first R. So the records that the transplant center is most interested in is really getting a full picture of what your medical history is. And then we are also trying very hard to figure out, how are your lungs doing? How are they doing compared to a month ago? How are they doing compared to a year ago? And that is going to help us figure out how quickly do we need to move to get you active on a transplant list. And it's going to color some of the things that we say at those visits. So all of your pulmonary function tests, the actual pulmonary function tests, you have that with a little label and a binder. That's awesome. Your actual CD of images is also awesome for us. And then many folks undergo heart evaluations when they first start complaining of shortness of breath. So if you've seen a cardiologist and you've had echocardiograms or you've had stress tests, like those reports are good. The images less so, because you're basically going to be seeing a pulmonologist. We're really good at looking at chest images. We're less good at looking at heart images, so we're good with reports for that. And then having your actual medication list with you is a huge help. So this is what is always or almost always said to me in clinic. So almost the first thing that's said to me. My doctor sent those. So I have been looking and looking and looking all around Charleston for lots of records, and I finally found them last week. And you know this is Charleston because there's different colored buildings, so it's real, they're right there, and yours are right in the middle of that. So electronic medical records are definitely making this a lot easier. Epic has the ability to connect with other centers that have Epic, and we happen to have Epic, but not all transplant programs are on Epic. And many, many folks go to a different clinic that maybe doesn't use Epic quite the same way. So having that list of things with you is actually just a really, really good start for your transplant center. Okay, I froze up now. I'm afraid if I touch the button again. All right. So now rehab, the second R, hugely, hugely important. It is one of the first things that I will tell people the reason why they're not a candidate is we got to get you into rehab. So if you can get started in rehab before you see me, you're way ahead of the game. So getting started before you meet the transplant team also demonstrates that you're committed to a life of exercise and rehabbing after the procedure. You will convince your thoracic or cardiovascular surgeon that you are a good candidate if you show that you've been adherent to pulmonary rehab. They're going to be very excited about you. In addition, it has a huge benefit. It really does improve quality of life. We've shown that over and over again. And my belief system is that the stronger that you are, for whatever insults that come your way, you're going to just be able to get through them better. So even if you're not a transplant candidate, you've already done the best thing that you can do for yourself. You've really started exercising. So 6-minute walk distance, this morning people were bashing the 6-minute walk distance, so like I thought about pulling this out of there. But the reality of the 6-minute walk distance is that it really has been proven to have good association with your risk of death prior to transplant. So if you have a really short walk distance, you're very, very sick, and so you have a high likelihood that if we don't transplant you, you're going to be in trouble. Unfortunately, if you have a really short walk distance, you also have a high risk of having a hard time after transplant because you can't rehab. So we're trying to find that sweet spot, and that functional outcome after transplant actually has to do with your 6-minute walk distance and then also the way that you behave before transplant. I often tell folks I'm transplanting lungs, not brains, right? Not habits. Your habits are your habits. So if we can get you having good habits ahead of time, it's a really, really, really good idea. So now the recent primary care, which again, if anybody's got a good idea for the R that will work for this, I'd appreciate it. So comorbidities are really common in our population. So when you see your primary doctor, I got to click just the right way with this. We really want you to have all of these very common problems kind of worked on. They don't have to be perfect, but if you're working on them, again, you're getting way ahead of the game. So diabetes and hypertension, these are two of the most common comorbidities or illnesses that travel along with transplant. They are the side effects of the medicines that we give after transplant. So having good control of diabetes beforehand is key so that we don't have real challenges after transplant. And then high blood pressure, unfortunately, at 5 years after lung transplant, it's like 99% of people are taking an antihypertensive medicine. So we really need to have good control of your diabetes. There are very serious consequences to having hypertension out of control, particularly early after transplant. So osteoporosis risk, many people have been exposed to prednisone and to other immunosuppressants, so your risk of osteoporosis, that should be assessed. And then weight, I can't stress the weight thing enough. If you're overweight, you're going to feel much better if we can help you lose weight. And then after a transplant, any extra weight that you have is making your rehab that much harder. It's like carrying a 50-pound pack on the camping trip or a 25-pound pack. No one's going to grab the 50-pound pack. And then I can't say enough about anxiety and depression. Unfortunately, access to care is really challenging for anxiety and depression, but it is a huge, huge component of the disease. And then it's also a huge component of the challenges after transplant. If you have anxiety and depression after transplant, it is much, much harder for me to get you up, get you moving, keep you focused, keep you really believing that in the end everything's going to be great. So tackling that problem ahead of time is a good idea. Cancer screening, everybody needs to undergo their cancer screening, and this is also another thing that really holds up that transplant evaluation. If you haven't had your colon cancer screening and it's not getting scheduled, right, that will keep putting things off. We need to make sure that you don't have an underlying cancer that we need to take care of. So that's hugely important. I didn't put immunizations on here, but immunizations are also important, making sure all of that is up to date. Transplant programs, if we really put you through a transplant evaluation, the full evaluation, we give you immunizations for hepatitis B. And so if you're looking like you're going to be a good candidate, really being on top of things and making sure that you get those immunizations is good. And then the dental visit is also another thing that is hugely, hugely important, making sure that there's not significant gum disease. Because first of all, dental stuff is expensive. Many people don't have insurance that covers that. And so you have to be prepared for that. And second of all, it's again another thing that can really hold up the ability to list you for transplant. So again, staying ahead of that. All right. So now this one, it's not necessarily your primary care physician, it's maybe your pulmonologist, but limiting your immunosuppressant exposure is really, really important. So one of the key things that centers for transplant outcomes, all of our outcomes are watched, and they have a predictive model of what's the risk for our entire cohort of how they're going to do. And that's a way that transplant centers are graded on if they're doing a good job or not. One of the things that is actually a major risk factor and will cause the predicted outcome for a cohort to really drop, so to be less good, is if someone is taking chronic corticosteroids. So minimizing how much corticosteroids or prednisone you're taking is a key thing. And unfortunately, as you get sicker with pulmonary fibrosis, a lot of times we will try some prednisone to treat an acute exacerbation or the underlying inflammation if we can turn that around. Corticosteroids chronically are not really a good idea for IPF, but as people get sicker, it's not unusual for it to be part of their regimen. Okay, so resources. So caregiver support. Can't say enough about this too. It takes a huge village to be able to get you through a transplant. And the reality is, so I'm the doctor, I've got the easy part. I just go in and say, you have to do this, and then I walk out. But you need help to do it. You really need, ideally, one really committed person. That one really committed person, though, they're going to get tired. They need a backup, and they need a social support that can really help them out. So asking for help, asking churches, friends, card support groups, like whatever is your thing that you do, fishing buddies, get them all to help out and step up, even if it's just to make a meal or bring you to the hospital for your appointments. The travel plan is really key, and this is just for the evaluation. The travel plans, as you get farther into transplant and how often you have to go back and forth to the transplant center, because most transplant centers are not right down the street. Those travel plans and figuring all that out, that really takes a bunch of time. And as you're thinking about that, and as you're thinking about if this is going forward, really having those preparations. So I have a patient who very recently told me they had 12 oxygen tanks in the car to get from where they were to my place to be able to hook up to my oxygen and get back home and have one oxygen tank for reserve. So it can be a daunting task. So having that plan is really important. And then transplant, unfortunately, it's crazy expensive. So the numbers I just saw an article that popped up today saying that the helicopter ride actually costs more than the transplant. And the numbers that they put into the article were not quite, they were right, but they're not quite right. The transplant costs way more than what they said. But that's okay. It's really, really expensive. And the thing is every insurance is different. So if you try to have that conversation with a doctor about what you need, I can guarantee you, unless they are a very unusual doctor, they have no idea. We have financial counselors for that to really help out. But fundraising is also a good thing. There's a lot of really nice people out there that are willing to help people out. You should let them help you because there's all these unexpected expenses. Relocating to the transplant center, as a general rule, if you don't live very close to the transplant center, you have to be there for at least 3 months. Some programs make people move before the transplant, so it could be longer than 3 months then. So food and lodging, and we all know, right, so we're here in this really beautiful place, right, but it's not home, and so where are we eating? We're eating the sandwich that they give us, and then we're trying to find dinner, right? So that becomes a very expensive ordeal in the transplant 3 months after the procedure. You have to keep in mind that your caregiver, your number one support person, a lot of those folks are working or they have other responsibilities at home. They got to kind of put that on hold. That's a huge stressor. Got to be prepared for it and have a plan. All of those medication co-pays. And so what we try to do at our center is we really try to make sure that we have that 3 months figured out for folks. And I keep telling folks we really need to have a plan for at least a year. The medication co-pays can really be crazy because we often are writing for antifungals and antiviral medicines that are just, unfortunately, they're very, very expensive. And then the reality is when you come to our transplant center, your home is still there. It still needs to have the grass cut, still has to have the lights on, still has to have all that stuff. And so you have to have a way to cover all that. And I think that the average transplant center, we don't talk about it much, but we do recognize that being away from home is a huge psychosocial stressor. You really can't underestimate that, and that's where I think having that support structure, particularly for that primary caregiver, to maybe even get a break, be able to go home, take care of stuff, have someone that's there to help out for a few days, that's a huge, huge help. Okay. All right, so now the initial visit to the transplant center. So each transplant center does this differently. So depending on what transplant center you go to, you may go to a center that does an evaluation. Okay, so the word evaluation doesn't mean what it means, unfortunately. So in transplant speak, if you get an evaluation to a transplant doctor or a transplant administrator or like people who are overseeing transplant, a transplant evaluation means that you got all of your testing done and you were presented at the selection committee and a determination was made as to whether or not you're a candidate. So then there's the other kind of evaluation, which is like a visit. So what we call that the initial clinic visit. And the way I do it in our center is I try very hard to see patients within 2 weeks of the time that I hear their name. And it's an initial clinic visit. It's a, hey, I'm Tim, what's your name? Let's talk about what transplant is and see if you're interested. Because I think it can be really daunting to put somebody through the full evaluation right out of the get-go. But some centers do that. So there's an in-between ground, this mini-evaluation. So the mini-evaluation is, well, let's do a bunch of the tests that we know can oftentimes rule people out. So they might look at your chart, and they might see that you have a history of heart disease. And if you have a history of heart disease, so they might do some heart testing when you come down. Or if you have a history of prostate cancer a while ago, they might actually draw a PSA and just see how that looks. But there's usually a little bit more testing that's involved, and maybe it's over 2 days or 3 days. Now, the full evaluation that typically leads to you being presented at the selection committee, that really is, I'd like to call it, it's 4 to 5 days of fun. Not really. So we draw a ton of blood. So the first thing is like 30 tubes of blood come out, and we send that all to the lab. And then we make you go get imaging studies. So we get chest imaging, we get images of your bones. We do imaging to determine how the blood flow is to your lungs. And we do a bunch of cardiac imaging, so echoes, and we do MUGA testing, which is a way of measuring the function of your heart. And then we also will do breathing tests, and we'll do 6-minute walk tests. And then we do organ-specific testing. And I put these two on here because these are the two most invasive things that transplant centers typically do. So we do put people through a heart cath. We look to see if you actually have coronary artery disease, and then we measure the pressures in your lungs to see if you have pulmonary hypertension. And then we also will do an evaluation of your esophagus, which is a little obnoxious. We take a small tube and we put it in through your nose, down the back of your throat, and make you swallow that. We measure those pressures, and then we take that one out, and we put a different one in, and we leave that one in for at least 16, 18, or 24 hours, depending on where your center is. And we tell you, we pat you on the back after we do that, and we say, act normally. We want you to eat and drink just like you normally do. So that's what we put you through in that 5-day evaluation. So that's how you know you got the real deal done. I'm going to figure this clicker out eventually. And then the other thing that takes up all of that time, of that 4 to 5 days, that testing is part of it, but then it's really the consultations. So this is everybody that's on the transplant team that we make folks see at MUSC, and it's pretty standard across the board. So you see the pulmonologist, you see the surgeons. Everybody sees our cardiologist to just talk about the risk of the heart cath. They like to say, hey, we actually are going to poke you with a needle, so this is what it's all about. But if we have questions about your heart, we actually have the cardiologist give their opinion about your heart. Transplant coordinators, can't say enough about my coordinators. They're awesome. They do a ton of education during that week and telling folks what they can expect and what kind of things that they may have to go through. We have a social worker meet with you all. We have a financial counselor talk about the money. We have the pulmonary rehab folks talk to you about what the expectations are for pulmonary rehab before and after transplant. And then we have the registered dietitian talk to you about what's a healthy way to eat. And we have our behavioral medicine crew really at our center. I can't say enough about our behavioral medicine team. They really help me figure out how best to communicate with you all. Some people are really good with pictures and seeing things. I'm one of those people. And some people are good with just tell me and I've got it, I'm good. And then also the anxiety and depression stuff that I mentioned. If we know the extent of that before transplant, we can totally help. We can actually make a huge, huge difference. And then our PharmDs take a look at your medication list. And then we present you at the selection committee. So now, all members, every single person that you met on that goes to the transplant selection meeting, and we talk about you. That's what we do. And I will tell you, so I'll give you a little hint, you are being watched. It's the reality of it. So now everybody has a bad day, me included, or multiple bad days, my colleagues might say. So bad days are okay, but really and truly, everything that you're doing and every conversation that you have, people are at that meeting, they're talking about you. So it is a good idea to kind of just have that in mind. It's a reality of the process. So we talk about everything. We talk about all the medical issues. We talk about whether we think, are we going to be able to find an organ for you? Do we think that you're going to have a good outcome? We talk about all of that, and we ultimately come down to the decision that you are either not a transplant candidate or you are a candidate. Okay, so if you're not a candidate, there's two kinds of not a candidate. There's unfortunately, this is a bad idea for you in our opinion. So we say you're not a candidate at our center. And then there's you're not a candidate right now, but if we can get you to go to rehab, if we get you to lose 20 pounds, if we get you to do this, if we can get the immunosuppression that you're taking modified, so modifiable things we will definitely work on. So a word about not a candidate. So I had a conversation first day that I was here. I was talking to a fella whose dad underwent a transplant in 2007. And he was told, and I'm going to share who told him. He wasn't a transplant transplant candidate because I think that these are great transplant programs. So it's just to the point. Even if a great transplant program tells you you're not a candidate, you can keep asking. So he happens to be from New York, so he went to his local transplant center. He went to Columbia, great transplant program. They said, nope, not a candidate. So then he was like, okay. I'm going to go to the next place that's a big place because I know a big place is more likely going to transplant me. So he went to Pittsburgh, and Pittsburgh said, nope, not a candidate. So then he's like, well, I'm all the way out to Pittsburgh. Cleveland's not that far away, so I'll go to Cleveland. Also a phenomenal transplant program. A lot of I know everybody that works at these places, great docs, great surgeons. Nope, not a candidate. He ended up getting his transplant at the University of Maryland. Also a good transplant program, but it's not talked about like those other places. He's 12 years post-transplant right now. So if folks say no, and that's literally, I heard that just a couple days ago, and I'm like, so if folks say no, and I'm one of the guys that says no, we're saying no for our center. It is an important thing to understand that the center decisions, they are individual centers. It is okay to keep asking. I think it's also a really good idea to really listen to what the center says to you, though. I do think that each of those centers, I suspect that they had very good reasons why they thought it wasn't a good idea, and they outlined those for him, but those reasons didn't resonate with him. And for that reason, he kept going. And so if you're hearing things back that you actually resonate with, and you're like, yeah, I see what they're saying, like, I get that, they actually are right, well, then that's kind of different. For this particular gentleman, I think he had a strong will to keep going, and it was 2007, and he was 70 at the time that he was transplanted. So that was at the upper limits at that time. So, all right, so how do we decide to put people on the list? So now you're a candidate, and you're like, great, put me on the list. And we're like, nope, not going to put you on the list. And you're like, but why not? Well, so decisions about who goes on the list and when, it really is influenced by multiple different factors. Maybe we really think that we can get you a bit stronger. We think you're okay. It's okay if we don't put you on the list. Different programs have different wait times. So my program traditionally has had a very short wait time. We transplant about 70 to 80% of our patients in about 30 days. It's actually changing in the last 6 months. It's actually gotten longer because the allocation system makes these lists change around. But in the past, we could get people transplanted in 30 days. So I have maybe a little bit more time that I could work with you to try to get you to be the best candidate you can be. The things that we are looking at as we figure this out, though, we know your blood type, we know how tall you are, and we also know if you have proteins in your blood that might react with donors. So if you have proteins that react with a lot of donors, well, we got to give you more shots at the apple, more bites at the apple to be able to find a match for you. So you might go on the list earlier than someone. If you're really, really tall or you're really, really short, those folks tend to wait a little bit longer on the list. We might want to give you more opportunities too. So that might be a reason to list you earlier. The allocation system, I'm just going to talk a little bit about this, but in November 2017, there was a lawsuit in New York City that was filed that said that the way that we're allocating organs is not just, it's not right. And the outcome of that was that the way that the organs were allocated first was by donor service area. So donor service area is essentially lines of where organ procurement organizations work. And so those are, and they are arbitrary, and they're goofy. There's no like real rhyme or reason to them, and so it's just really confusing, and that was the argument. This is not the way that we should be allocating a limited resource. And so the fix to that is that we now take that first pass as a 250-mile radius. So it's 250 nautical miles from the donor hospital. So I live in Charleston, so Charleston is kind of down low on the map, right in there. And I centered this one, I think I centered it on Raleigh, Durham. So if there is an organ donor at Duke, then the programs that are actually encompassed in this, there's Charlottesville, so that's UVA. Baltimore, so you've got Hopkins and the University of Maryland. You've got Chapel Hill, UNC, and Duke, and MUSC. So you see Atlanta is kind of on the edge over there outside of the circle, so Emory doesn't get a bite at that apple on the first pass anyway. So everybody that's on the list at each of those centers, if they're the blood type, the appropriate blood type, that's the list that gets run. So for all of those centers, maybe there's 50 people. So if your score, so your lung allocation score, that decides what's your risk of death without a transplant. The higher the score, then the more likely you are to die without a transplant. That actually puts you closer to the top of that list. So you can imagine if I get an organ offer from Raleigh, I've got a list that looks one way for you. Maybe you're going to be number 30 on that list, but now I get an organ offer from, and I think that is centered on maybe Orlando. It's maybe centered out on the water. I did it on purpose so that I get Miami in there. So the interesting thing about this circle, so from Miami to Charleston is actually just under 500 miles. So this is actually the second bite of the apple. If there's an organ in Miami, the only transplant center that gets a pass at it after everybody within 250 miles, which is basically all of Florida, the only transplant center that gets added to the queue is my program. Now, so that's maybe an advantage, but remember, there's a lot of dolphins in that too, and dolphins don't donate lungs, so maybe it's not an advantage. But you can see that in that scenario, it's a totally different list that you're competing with. Now I'm competing with the entire state of Florida. So you might actually, you could be number 10 on the other list, and you could be number 100. It really depends on what's going on in those. And the transplant centers, they are aware of this. All right, so now I'm gonna book, because my time is up on the time that I gave myself that was short on purpose, so to go faster. So I'm just going to show you things that I think are really positive about transplants. Some of these graphs are kind of hard. I don't think that they're the best way to present the data. But basically, this is marching across from 2006 until 2016 of how many people get transplanted in X amount of time on the list. So if you look at the pinkish line there, about 70 to 75% of the transplant list gets transplanted within 1 year. Interestingly, there's a bunch of people that stay on the list for 3 years and even 5 years, which doesn't make a lot of sense to me. Those are folks that maybe shouldn't get transplanted. They're maybe not quite sick enough. But there's something interesting about that cohort that's just a little different. So the good news is if you look at 2016, if you look at 2017 and 2018, the lines are going up. People are, in fact, getting transplanted faster. That is a good thing. It means we're doing more transplant, so that is good. The other thing is that this is a graphic of the percentage of candidates that are listed that get transplanted within a year. So I mentioned in my program, we typically have a short wait time. You'll see mine is dark blue. We don't have anybody who doesn't get transplanted within a year. So we're unusual, though. There's only a few places like that, and there are people that it's 50%. So this demonstrates that depending on where you are in the country, you can get on lists at different times. And then the other thing that it really raises the question about, which is what the lawsuit was all about, is, well, wait a minute, how are we allocating this limited resource? And I will tell you that right now, UNOS is working hard on something called a continuous distribution system to try to make this more equitable and ideally clearer to folks. Okay, so my last little bit here. I'm going to tell a story of a transplant. So the wait, the call, and the outcome. So this is one of my patients. Lorcan is his name. So Lorcan, I moved to MUSC in 2010 to restart the transplant program. We hadn't done any transplants at MUSC since 1997. So they recruited me and a couple really good surgeons, and they said, let's get this thing back off the ground. So Lorcan was a patient of one of my colleagues back to 2007. So if you look to the top left, you'll see that that's his set of pulmonary function tests in 2007. He was diagnosed with rheumatoid arthritis-associated interstitial lung disease. He never really had a lot of joint complaints. He started with a little bit of joint complaints, and then he never had them again. So there was a lot of question about whether, in fact, he was maybe really IPF or not. So in 2007, that means that people were probably telling him, you know, we're really worried this is going to get bad. We got to keep a real close eye on you. We think you have rheumatoid arthritis-associated interstitial lung disease, so we're going to give you some prednisone. We're going to treat you with some Cytoxan, which is pretty toxic stuff. And then we're going to give Rituxan, which is also a tough infusion, because his breathing tests got worse. And then they got better when we gave that immunosuppression. They felt better about them. So remember, this is 2008. It's 2 years before I even show up in South Carolina. But people are really worried about him. His doc was talking to transplant centers at that time, said, I got this guy, I'm really worried about him. But he responded to therapy. So I end up meeting him in 2010. I arrived at MUSC in March of 2010. Like about 2 weeks after I got there, I met Lorcan. And people were really worried because his breathing tests, they had crumped again. And in fact, they went from even worse to when they gave him the Rituxan the first time to now they were getting progressively worse. It was now October of 2010. And then they kept going down. Lorcan was seeing me in the clinic, and he's like, do you think it's time? Is it time? And I'm like, we're getting really close. You got to keep exercising. He started dragging oxygen around with him, and I'm like, I think it's time. Let's get you on the list. We got him on the list. No organ offers. He ended up getting admitted to the hospital with an acute exacerbation, and so air on an X-ray is dark, and so your lungs should be nice and dark. If they're full of white, then that means that there's a lot of fluid and inflammation in there. So he was on 100% oxygen at the time that that picture was taken. I was really worried that he was not going to make it past the next 24 hours. Having really tough conversations with his wife, and then we got the call. So we did the transplant within 24 hours of his arrival with the acute exacerbation. We got a beautiful chest X-ray immediately post-op. His lungs are totally clear. He looks really good. We got him extubated within a day. And then this is the current X-ray that was just taken in clinic. Very normal-looking chest X-ray. People think he's had a heart surgery because the way we did his surgery, we actually did a sternotomy. And this is Lorcan here. And so the top left-hand corner is he was out on the beach earlier than he was supposed to be. So I want to say that that was about 2 months post-transplant. I kind of got mad at him. But he's got a hat on, so that was good. Then Lorcan is a very active guy, and he was a very avid athlete before he became ill. So he's playing tennis. Again, he's got a hat on, so that's good. He won that race, believe it or not, but he was the only over 50 person in the race. But it's all right, he won that race. And then this last picture here is Lorcan this past weekend. He rode a 50-mile bike race And the guy that's standing next to him is the guy who did his surgery. So, yeah. So Lorcan will tell you that none of that could happen without his donor. So I just remind everybody that unfortunately there's always a sad story that's associated with every great outcome. So make sure everybody signs their donor cards. It's hugely, hugely important. So the take-home points, really and truly, I think if you got pulmonary fibrosis, somebody should spend at least 10 minutes talking to you about transplant, even if it's to tell you stuff you really don't want to hear. But they should spend some time talking to you about transplant, and they should really consider referring you for transplant. If you undergo a full evaluation or you get referred for that transplant, it takes time. Those 4 R's, records, rehab, recent primary care visits, and resources, hugely important to do. And then listing really does depend on that local transplant center. And asking questions, ask them those hard questions. How many of your patients are dying on the list? How come you're not transplanting? How come you guys only did 20 transplants last year? What's up with that? I get that question. That's how many transplants we do, right? So you should absolutely ask those hard questions, and the doc shouldn't put up they shouldn't get guarded about that. They should be very open and honest about what's going on. And then lung transplant is definitely cool. So thank you very much.